So I'm going to try to provide some background as to why this forced diuresis, Lasix, use of Lasix, we may be seeing something beneficial in this kind of a trial, whereas, you know, every time we've given furosemide in other trials, things don't turn out so well. We could start with the question of why do more studies, and the answer, I think, is here. There are a lot of things that happen associated with developing acute kidney injury, both in the short term and the long term. We really don't have a reliable strategy that everybody agrees on, that where there's consensus that we can prevent the injury. And yet, it's the perfect opportunity for a preventative strategy because we know exactly the patients ahead of time. So that's part of the reason. The mechanisms by which contrast and which may be impacted by this particular therapy are ischemia and hypoxemia. We know that contrast reduces renal blood flow, particularly in the medullary portion of the kidney. It does that by inhibiting nitric oxide synthase and nitric oxide availability, in part because of the physical characteristics of the contrast agent. Some evidence, and I put a question mark here, that viscosity may be more important than osmolality for that particular mechanism of action. There's also direct cell toxicity. Contrast taken up by the cells of the kidney. They try to metabolize it, damages mitochondria, leading to stimuli for going down a pathway of apoptosis. So what's the hypothesis here? The hypothesis is that a high urine flow rate will dilute out the concentration of contrast within the tubule lumen and decrease the contact time between contrast and the renal tubule. So this should address the mechanism of cell toxicity. And there may be other mechanisms that we don't know about that also impact the hemodynamic effects of contrast, like the increase, this therapy may increase medullary blood flow. So what's the background for thinking that high urine flow rates might be protective? It's not what was your grandmother told you, that everybody needs to drink 8 glasses of water a day and that'll help your kidney. It's that in trials of contrast-induced nephropathy, a high urine flow rate seems to be associated with less incidence of a rise in creatinine. And this is the Prince trial. This is the quartile of urine flow rate achieved in the Prince trial. I'm not going to tell you exactly everything that they did, but they gave furosemide, they gave Valium, they gave dopamine, they gave mannitol. There was a very complicated protocol as to how patients would get those things. This is the incidence of it. This is the change in creatinine as you go from the lowest urine to the highest urine flow rate. That change in creatinine seems to go down. This is if you plot sort of all the patients. And you can see that the change in creatinine seems to drop as urine flow rate goes up, suggesting that there's something that a high urine flow rate is doing to minimize this marker, creatinine, of kidney injury. All the definitions of injury to the kidney, this is the low urine volume, the high urine volume. For any definition, the higher the volume, the lower the incidence of hitting that threshold. And they chose here as a cutoff 150 ml an hour of urine volume. So if you look at this slide, here's the 150. But if you look at the zero change in creatinine, it's not at 150. It's out here at somewhere around 200 plus ml an hour. Now, there have been, that trial is a number of years old, but it's informed us about whether or not urine flow rate may be important, and people are still doing this. So here's something, very recent, suggesting that the effects of hydration, this is with primary intervention, suggesting that hydration, let's see if I got this. No, here's the actual data. This is the incidence of contrast-induced nephropathy as you move to a higher urine flow rate in this trial. This is the numbers of whether you got the urine up at the beginning or at the end of the treatment. And we'll leave that for the moment. But the point is that the higher the urine flow rate, they went from 26% to 17% to 8% incidence of contrast, what they're calling, what we all call contrast-induced nephropathy. So this is still, people believe that a high urine flow rate is out there as a key to preventing kidney injury. This is another, this is the same trial in which the hydration volume was significantly associated with preventing contrast-induced nephropathy. So this is less than 960. If you were less than 960, you had a threefold higher rate of developing contrast-induced nephropathy. It was more powerful than the TIMI perfusion state and whether their LV function was damaged or not. Here's another trial a few years ago. Basically, forced euvolemic diuresis with saline, mannitol, and furosemide. Compared with saline alone, all patients received 500 of half-normal saline before angiography. 8 hours after, they replaced in the way that we typically replace urine output. Nurse measured it at 1 hour. It's X. For the next hour, they give X back. And so they're always an hour behind. And in this study, they said, cannot determine whether there was any benefit to doing this. So that while people are still doing this, still giving lots of volume, giving furosemide, trying to show a benefit or not, we still have a lot of controversy and a lot of unclarity about whether it really works or not. This is that study in which they showed the percent of CIN. This is the intervention group. This is the control group. Okay? Different definitions. Look carefully at the slide. It's showing that giving furosemide and replacing the volume is worse. Now, I had the unfortunate experience of being the person almost 20 years ago who first published data like this that said giving furosemide and trying to force the kidney to make urine actually increases the rate of contrast nephropathy. So here you're sitting in this meeting, and we're going to try to convince you to do exactly that. And I'm trying to be balanced here. I'm showing you here's recent data. This is 15 years after the original trials that we did. They're finding the same thing. So what's going on here? The evidence suggests that a high urine volume seems to be protective. Yet, it appears that if you force it, particularly with diuretics, that's worse. So how do we sort of bring those two observations together? So here are that's the last trial. This is a trial done 5 years ago. That was the original trial back in 1994. There's the data. Not a huge number of patients here, but boy, there's nothing in any of that data on this side of the vertical line that suggests this is a benefit. And in fact, when these guys first went to the FDA, that was the FDA's first issue. You want to give furosemide to patients who already have renal disease to try to protect against contrast nephropathy? Don't you read the literature? Because that's the literature. Now, what do all these trials have in common? And this is what they have in common. Dose of furosemide, high. Weight change. Now here's the control group. Gain, little loss, gain. Here's the group that gets the furosemide. Loss, loss, loss. In all of those trials, our standard of care for replacing urine output, measure for an hour, give back that the next hour, doesn't work. It just doesn't work. You get behind. None of these patients got an upfront bolus. They all end up with volume depletion. And whether it's the volume depletion that by pre-renal effects raises creatinine, or volume depletion stimulates the sympathetic nervous system and interferes with renal blood flow, whatever the mechanism is, it's not good. So possible explanations: inadvertent volume depletion, activation of the renin-angiotensin, renal vasoconstriction, delays removal of contrast out of the kidney, allows for more of that medullary vasoconstriction and direct cell toxicity of the contrast. And there's some evidence that high-dose furosemide actually vasodilates in the cortex of the kidney. I mean, you know that when you give it to somebody with pulmonary edema, it dilates the veins. They come out of pulmonary edema or their shortness of breath gets better long before they make a drop of urine. So similar effects occur in the kidney, and it may actually be shunting flow away from the medullary portion of the kidney, sort of stealing blood from the medulla when you use high dose. So what's the RenalGuard system? Well, the RenalGuard system is no volume depletion. You bolus them up front with some saline. You replace, we saw 99% of what comes out in real time. They never get behind. And we've got relatively low doses of furosemide. So in the other studies, you're giving more than 1 milligram per kilo of furosemide. Here we're somewhere between 1/4 in the Brigori to 1/2 in the Bartarelli experience with those two trials. So that's the system. That's the urine output. That comes out of the same slide that you just saw. This takes a relatively short period of time to get to. Here's the 150 ml that was in the Prince trial. Well above that. We're certainly above the 240 ml where in the Prince trial there was no change in creatinine. That's good out for 6 hours. So why all the fuss still about trying to find a strategy? Well, it has to do with all of these adverse outcomes. One of the things that's hard in this business is to convince, and I don't say this for any of the people in this room, but there are your colleagues out there who believe that this is not a real injury to the kidney. And because the creatinine goes up and comes down, even if something did happen to the kidney, it's of no consequence because they get better. And so the idea that the kidney should be important when you're more worried about restenosis and bleeding and the other complications of the procedure it's not high on the radar screen. You know that there are these long-term consequences that have been described in lots of papers about worse cardiovascular outcomes if you look 6 months down the road in people who get CIN versus those who don't. And we've believed for years that all we're seeing there is a marker of the severity of the comorbidities in that patient. The patient who's got the most comorbidities, they're the ones who get the kidney injury. And the fact that 6 months or a year later something happens to them has nothing to do with the kidney. It's just that they have diabetes. They've got a bad left ventricular ejection fraction. They've got a lot of vascular disease. So this is the dialysis, the death in this study. This is just published. This is the one I want to talk about. Chronic kidney disease. The idea that when you injure the kidney, even though the creatinine appears to come back to normal or back to baseline, that there's something that happens to the kidney long term. This is data. Let me just take you through this very quickly. This is the rate at which GFR falls. It's the slope. Here are normal people. These are the people who do not have contrast-induced kidney injury. There's no, when they look later, years later, no change in the slope of kidney function. Here are the people who had injury. These are normal GFRs to begin with. Here are people who had chronic kidney disease and kidney injury. So their slope, to begin with, there is a slope. They're losing kidney function. But if you got an injury, the slope increases. They're losing kidney function faster. If you had chronic kidney disease to begin with, you're losing kidney function. But if you had no injury, no impact on the kidney. And here's what it translates to in terms of how long it takes before you would end up on dialysis. So chronic kidney disease patients, no injury, 8 years, 9 years, they're the same. If you get the injury, you go from 10 years to 4 years. Okay, small study, small. This is our data on about 1,200 patients from our cath lab. We took the cohort 2008 to 2009 or 2007 to 2008. We could go back 9 years in our system. Here were the slopes of the people with no injury. And here were the slopes of the people who were going to end up having contrast-induced nephropathy. This is all comers. So these are the people who have chronic kidney disease, as you'd expect. These are the people with well-maintained GFRs. So these people have a slope. This is the serum creatinine has been rising over 9 years. They get an injury, it goes up after the cath. But interestingly, we found the same thing happened even in the normals. Now, that's 1,200 patients. This is the epidemiologic view, 25,000 patients, all who undergo cardiac angiography, of whom only a small number had renal disease to begin with. Most of these do not have any renal disease. Mortality. So this is by Aiken stage of kidney disease. This is no damage, no change in creatinine. Stage 1 is the 0.3 milligram per deciliter increase that Charlie showed you in Carlos Bergori's definition of CIN. And this is greater than 0.5 or doubling. Mortality, we expect that. But how about end-stage kidney disease? People who get this injury, even though they were most of them are normal, 24,000 of them had normal kidney function to begin with, you still have a significantly higher risk of going on to end-stage kidney disease. And here's where I worry that it really is the initial kidney injury that is the cause, not the marker of, but the cause of these events, is that there looks like there's a dose-response relationship to mortality. So you go from no AKI to mild to severe. End-stage kidney disease, no AKI, a mild initial evidence of damage to more severe. So whatever you look at, heart failure, acute hospitalization for renal disease, it looks like there's this dose-response relationship. More AKI initially, worse outcomes way down the road. Biologic gradient. So, you know, it's possible, just a hypothesis, that this thing that we call contrast-induced acute kidney injury is just the very tip of the iceberg. That there really may be a lot more going on. I mean, progression to kidney disease. We have no idea how often this really occurs. How often do you get to follow up on your patients 2-5 years down the road and monitor what happens to their kidney function? And what about the patients with normal kidneys who didn't have a bump in creatinine, and yet it looks like their slope of their GFR has changed after they got exposed to the contrast? What about those people? I mean, in the United States, I think we're somewhere around 3 million caths per year, and now with TAVI and the T-bar and other things, there's going to be more dye given to patients. It is possible that there's some injury that occurs every time we give contrast. So finding a way to get that contrast out of the kidney, get it through the kidney as quickly as possible makes a lot of sense. And, the RenalGuard may be one way to do that.